So, hi everybody. My name's Adriana. I go by Dr. Levine at Bayside, and I'm a residential treatment therapist at Bayside. I'm one of the clinical psychologists that we have. Oh, that's fun. And quickly before we get started, I just kind of wanted to tell you the reason for this presentation and really the reason that I'm doing this community education. So about 2 years ago, I came to Bayside, and I come from a background of working in trauma-informed care and working specifically with the LGBT queer community. And so it was really important to me that substance use be part of this, because as I was working in the community, I was seeing some serious disordered eating, I was seeing some serious substance use, and I wasn't able to really find tracks or funnels for that community to go in. And so when I came to Bayside, they were incredibly flexible and incredibly desiring of this kind of care, but didn't know how to kind of spearhead it, so that's where I came in. So Bayside is a residential treatment facility, and we're dual diagnosis. So we work with substance use and we also work with mental health. We are in Marin, California. And the one thing that we did with wanting to provide affirming care is we made sure that we weren't just welcoming, because that's something else. We wanted to actually be affirming. And what that means for us is that we changed all of our bathrooms to gender neutral single occupancy bathrooms. We no longer have any binary or gendered process groups, therapy groups, hot tub times have changed. All of those things have changed to really accommodate that anybody who's living along the continuum and who doesn't really buy into the binary or doesn't identify that way can still use the services. So what that also means is I train all of our kitchen staff, our drivers, our medical staff, our clinical staff, our admissions, the people who work at the phone call centers who get the initial assessments, I train them. I go into the community and I train. What else? We've trained our sales force, so we've changed all of the drop-down menus, which means that someone can call in and say, I use these pronouns and I need treatment, and we know how to respond to that. So really, we kind of went in and did an entire restructuring of the program so that we could really meet everyone's needs. And by the way, if you have any questions, if you want to do a tour, if you want to come talk to us, meet us, figure out what our programming looks like, I have Mila here, who's the director of marketing, and we're happy to do tours and all of that. So kind of a roadmap here. So I think about this as bigger than diversity or beyond diversity, because I feel like when we talk about diversity, we're talking about difference rather than what's the same. And I think often when we start with difference, it becomes a me and a you, or us and them, and I would rather like it to be all of us collectively making decisions collaboratively. I come from the stance of cultural humility, which means that I am always looking toward the other, so I take an other-oriented stance. And what this also means is that we're dedicated to lifelong reflection. So, for example, in our clinical consultation, a lot of our conversation is around ethnicity, around community, around social economic status, around gender identity, around sexual orientation. So we try to stay consistent in our education for ourselves and how we reflect on it and how it impacts our clinical dynamics. We work toward fixing power imbalances. So I know that when I walk into a room and I'm using the moniker Dr. Levine, that instantly changes the dynamic in the room clinically. And so I get the choice of how I communicate then to that client about our power differential and how we can work collaboratively rather than in a power structure. And then lastly, we work to develop partnerships with groups who advocate for care. Okay, so throughout this, I'm going to be framing it in the minority stress model, and we're going to talk heavily about microaggressions. And the reason that we're going to do that is because microaggressions deeply impact clinical care, as they impact really anything that we interact with, any person that we interact with, any institution that we interact with. And so what we're going to be doing is talking about microaggressions and the minority stress model as it relates to the LGBT community and how it impacts access to care. So the minority stress model is a theoretical framework that frames the sexual minority health risk. And what that means is that by living in a hostile environment, by living in a homophobic environment, by living in a society that tells us we are not safe, our health, the community's health, is then put at risk. So what this also means is that we have to really deliberately come face to face with stigma and how stigma is affecting our clients. So stigma affects our ability to get, maintain, and keep a job. It affects the ability to be in romantic relationships that are healthy and safe, that keep us away from STIs and HIV. It also impacts the mental health of that person, their ability to get treatment, and their ability to trust the institution that's providing that treatment. It also makes it harder to be open about sexual orientation, and it increases limited social support and increases isolation. So what are microaggressions? Just a raise of hands, how many people in this room already knew what a microaggression was? Great, okay. So that means that we kind of already know what we're working with. Do people understand what a microaggression would be in the context of the LGBT community? Yeah, okay. So microaggressions are subtle, stunning, sometimes automatic nonverbal exchanges that tell us we are less than. A microaggression, again, is nonverbal. It could be behavioral, it could be environmental, and it could be very, very brief. And that's one of the things that makes it so difficult. So sexual and gender microaggressions are behaviors, whether verbal or nonverbal, environmental factors that let us know that we are at a lesser than position due to gender identity or sexual orientation. Okay. So this is from the 1970s, and it was originally used to discuss microaggressions based on race and ethnicity. So for example, asking someone, what does this word mean in your language, right? Or saying, I don't see color. For example, a store owner following someone around in a store. Or the example that I like to use very often that's very subtle is clutching a purse when someone's near you and you are afraid. So it's first defined as a brief and commonplace daily verbal and behavioral environmental indignity. And I think what's really important here is to notice that the word indignity is being used. This tells the person, A, they have no dignity, and when that happens, it makes it very difficult for that person to access care, advocate for themselves, or even trust the institution that's going to provide the care. And lastly, this has been expanded to different religions, to women's issues, to the LGBT community, and also to communities of people with disabilities. So these are some of the examples of LGBT microaggressions that come up often. So using incorrect pronouns or using someone's dead name, for example, when that information is already known. And again, this is very slight, right? This is not intentional, but it's something, if we already have the information, we should be that much more mindful and that much more thoughtful about how we address that individual. Ignoring requests for modification or adjustment for non-binary clients, saying, I'm not homophobic, my best friend is gay, right? Or saying, no homo is one that we hear a lot, or that's so gay. We think that this vernacular has kind of, been sifted out, but it really hasn't. And this is something that among the community of clients we hear very often, and we have to kind of interrupt. Limiting definitions of family to biological family for a community for so long who either has been kicked out of families or extradited out of their families. It's really important that we really adjust our ideas of what family looks like. Referring to someone's partner in gender terms. This is one that can get really tricky, right? So sometimes sticking with spouse, partner, those things are a little bit easier because we can never assume the sex or gender identity of someone's partner. Expressing frustration or annoyance when we have to modify language. And subtle snubs or dismissive looks, gestures, and tones. And these things we'll get more into, but for example, the expressing frustration or annoyance, this might happen, for example, when we find ourselves slipping up on a pronoun. Maybe we can't get it right, that we want to say they, but we're not getting it right. The thing is, if we go, for example, if the client is there, whether or not it's about our mistake and us being frustrated with ourselves, that client then takes that in, internalizes it, and said, I'm never going to ask for another accommodation again, right? Okay. So before I start talking about this, I always get curious, what symptoms or what diagnosis does this remind people of? Any thoughts? So if we see someone who's acting out, who's really aggressive, maybe they raise their voice faster than others in the community. Any thoughts? No? So,
Schizoaffective.
Did you say schizoaffective? Close.
Good try. PTSD.
Thank you. Say that louder.
Oh, PTSD.
Yeah, ring a ding ding. So what we see is that in clients who have experienced consistent microaggressive language, behavior, dynamics, we find that they're faster to anger, they raise their voice more, they feel powerless, and they feel like they are consistently not heard, even from sitting in front of them and saying, I hear you. They feel a lot of pressure to represent one's group, which causes them to do the opposite. It actually causes them to isolate and to retreat from the provider, and feeling hurt long after the incident occurred. This one is very important. So if we think about the anger, the feeling of powerlessness, and feeling hurt long after the incident occurred, these line up very specifically with PTSD, and I'm going to get into CPTSD in a little bit. But this one's very important because, for example, we have clients who come in who are trans-identified, who most often do not feel that surgical intervention is necessary. What that means is that we have clients walking around using him, her, or him, he pronouns who maybe have a full chest. And what we have to do is really challenge what we think a female body looks like or a male body looks like, and this is consistent work for us as providers. And one example is I had a client who I worked with for 60 days who had an immense amount of trauma, very severe PTSD, and the trauma actually is not what was most upsetting to them. It was that someone said, there she is, when they walked into a room. They could not get past it, and we spent about a week or a week and a half talking about why it was so upsetting to them. And it turned out that the she, her pronouns and the there she is kind of announcing this person into a room made the person feel like they needed to out themselves to the entire room in order to feel heard. And this is something that they had to do with their family. They had to out themselves to their religious community. They had to out themselves, even coming into substance use treatment and telling people how they identify. So it was this consistent experience for them, and they sincerely could not let go of it. And it's something we had to process for a very long time. The other thing is that because they felt hurt long after the event occurred, they felt ashamed that they couldn't let go of it. Why am I holding on to this? Why can't I just get over it, right? Well, they couldn't just get over it because they've had about 35 years of that experience. Does that make sense to people? Okay. So microaggressions impact on the therapeutic dynamic. Well, first and foremost, we notice that safety suffers. If a client doesn't feel like they can be authentic, they're not going to feel safe fundamentally. And at Bayside, what's really important to us is that safety and stabilization are the primary thing that we work on. So communication suffers. I think often what I see is a real lack of vulnerability and authenticity for clients who don't feel safe. It contributes to the client not feeling seen. And overall, it can contribute to a discontinuation in services. So this is something really important. When I did this presentation recently, I had a couple people say, yeah, this one person really wanted care. I made one mistake and I couldn't get a hold of them again. And I think what this is about is not just that the mistake occurred, because those are going to occur, but it's how do we come back after that, and how do we, fix this rupture that happens therapeutically. Okay, just taking a nice breath. Okay, so I think most of us know what trauma is. It's defined as actual or threatened death, serious injury, or sexual violation. For the people in this room who are familiar with working with the LGBT community, or for people who even aren't, do you know clients who have experienced one or almost all of these? Raise of hands. Yeah? Okay. So this is really important because what we're getting into is the idea that microaggressive experiences among the LGBT community is trauma. It's consistent trauma, and it makes it so that the coping skills that someone outside of the community might be able to use are less accessible to these individuals. So when people face discrimination in their lives that's intense, extensive, and enduring, that maybe threatens one's safety, it causes symptoms labeled as traumatic discrimination. Anybody heard of traumatic discrimination here? No? Okay. So this is really important. So for example, 2016 was the most dangerous year on record to be an LGBTQ member. And the reason is that that's the year that the Pulse nightclub shooting happened. That was, 45 people of color who also identify as queer who were instantly told you are not safe even in your own space. So if we think about that, what that tells the individual is that consistently long-term, I will not be safe in the world. And what that shows up as is traumatic stress symptoms. So lastly, this kind of leads into my talk about microaggressive trauma, which is extensive and continuous exposure to subtle discrimination. So this is the subsequent symptoms that result often look like PTSD. Now, where it gets complicated is that we don't have a diagnosis for CPTSD yet in the DSM. Okay. So psychological dilemmas of microaggressions. As I'm talking about this, I'm curious if anybody in the audience is sitting there saying, oh no, I messed something up, or oh no, I've messed something up with a client and I don't know how to come back from it. These are the things that happen as a result that are really important to think about, and that maybe because we're often not on the other end of the exchange, we don't realize. So, clash of realities. If someone clutches their purse, and I say to them, I just saw you clutch your purse, what's that about? And they say, oh, no, not about you, it didn't happen. Well, that's gonna make me feel as though I can't trust my own reality, I can't trust my eyes, and I can't trust how I feel, right? So that tells the individual what you're experiencing isn't real, and it really challenges that person's ability to trust themselves. So again, the invisibility of unintentional bias, as I said, it could almost be a glance, right? It could be something that's really, really passive that maybe we're unaware of. However, if it's invisible, how do we address it? We then, and I'm outing myself as a queer person, we then have to say, I just saw what you did. And if we already don't feel safe in society and we have been told that we are marks for death or for harm, why are we going to out ourselves and say, I just saw what you did, right? So there's also the perceived minimal harm of microaggressions, which is, oh, it was just an eye roll. That's not hurtful. Well, what about 25 years of eye rolls? Think about how cumulative that experience is. And then the last one is the catch-22 of responding to microaggressions. So, for example, if I mess up a pronoun, I very gently say, I'm so sorry. I know I got your pronoun wrong. I will do it better next time. And usually we can move on. But if we...
Yeah, I just have a quick question. The population that you're treating, I'm sure that there's personality disorders a lot of times coming into treatment. And I know that sometimes people who do have a personality disorder can see a situation as being, or even just a lot of trauma, as being threatening, that maybe really isn't. How do you kind of differentiate that and have that conversation?
It depends in both and. I think what that question, is asking is two things. What do we do for LGBT community members, and what do we do with people who have personality disorders? And fundamentally, safety, communication, the fact that they don't have to speak for their own group, the fact that they don't and shouldn't be teaching me, all of those things still apply. So just as someone maybe with borderline personality disorder, I am not going to ask them to represent the entire group of someone with BPD, right? So it really actually does all apply. And if there's behavioral issues, there are going to be behavioral issues, and I'll talk about that. But that's where we start to work collaboratively instead of saying, can you brainstorm how to fix your problem, right? Instead, we work as a community, as a group. Did that answer your question?
Yeah.
So, and lastly, that just the catch-22 is that if we respond in a way that explicitly shows our intense discomfort, that client is not going to feel comfortable correcting us or the staff or other clients. And so I try to be really thoughtful of saying, I messed up, I'm a human, and I see you, right? So I know that you are struggling. I know that this is something that probably happens at least once or twice a day in your life. I see you, and I make mistakes, and I will try harder. It's the moment that we have an alarm that goes off and we fumble over ourselves and we over apologize. Do you know what happens then? Guesses?
You start taking care, the person starts taking care of.
Yeah, so the client then starts taking care of us and saying, oh, don't worry, it's okay. And we don't want that to happen, right? We want to make sure that the client fundamentally feels safe and that we can properly take care of them. So getting into complex PTSD, so it occurs when someone experiences extreme violent stress over an extended period of time. So previous research on trauma suggests that it results from witnessing actual or threatened death, serious injury, but it's also been expanding for a number of years. And now it's found that there's a relationship between persistent trauma, social disruption, and how those things go together. So I'm going to give you an example. We're in the month of Pride, right? 5 Black trans women have already died this month. And the reason that I'm saying that, I know that that's very heavy, but the reason that I'm saying that is because there's a real, honest lack of safety. And for someone who is a Black trans woman, maybe she's living on the down low, maybe she doesn't have a partner, maybe she can't get a job because she hasn't had feminization surgery. Imagine her load of stress. Imagine the amount of complex trauma she's holding, right? And so if she comes to us and she needs treatment and she wants to get into residential and maybe she raises her voice or maybe she's a little bit physically aggressive, how else does she know how to communicate, right? So I'm framing this with CPTSD because it's not something that's in the DSM, therefore I think it doesn't get talked about very often. However, traumatic discrimination is happening. It has happened already, and it's something that's showing up very heavily in substance use treatment. Okay, so I'm going to take a little break, see if there's any questions before we get into what we do, what affirming care is. Any questions? No? Okay. Is it making sense so far, folks? Okay. So affirmative care. Affirmative treatment is us stepping into someone's shoes and saying, your identity and your relationships matter. And not only do they matter, but I have compassion for what you're experiencing. And sometimes, yes, it's hard to find compassion if you have a client yelling in your face. And at the same time, they're yelling in your face because they don't know how else to be heard. And so we as a team work very hard to step back and collaboratively say, this behavior or this thing that's coming up in treatment is just a symptom of a larger problem, and the larger problem is oppression, microaggression, and traumatic discrimination. So LGBT substance use does not necessitate a new form of care. It necessitates us getting educated and really understanding that we have to both adapt to the client's needs on an individual level and understand that they're coming to us from a history of stigmatization from a larger society. So the clinical environment demonstrates cultural humility in that we reduce the fear of discrimination on the outset. So one of the things that we do is before someone even comes to Bayside, they have to sign an anti-hate speech and anti-hate behavior policy. If they cannot sign that, then we say, we'll give you referrals. Because we feel really strongly that if we can't create a safe place for care, that person's going to bounce out of treatment anyway. And then what is that? That's another failed attempt at care for those people who couldn't help me anyway, right? Does that make sense? Okay. So affirming practices recognize that the LGBT identity does not inherently lead to behavioral health problems. The behavioral health problems are being caused by a society that is hostile, that tells us that we are not safe, that tells us that inherently we don't matter, and it compounds on existing mental health issues. An affirmative treatment provider is one who recognizes social community. Like I was saying, we can never assume that someone's family is going to be biological, and for a lot of the clients who are coming into care, all of the releases they're signing are for close friends. They don't have any family, or they don't want their family involved because they'd rather, someone who's homophobic not weigh in on their substance use treatment. Okay, so being an affirmative provider, for us, it means a couple of things. The first, it means self-reflection. So us therapists, we meet every Thursday as a group, and we talk about what's going on in our lives. And the reason that we do that is so that we can really check what's going on with us versus what's going on in the community. Because we want to be thoughtful that we're always engaging in self-reflection, and that projection of what's ever happening for us is not being projected onto the client. That way we can help them the most authentically. So we want to get involved. We live affirmative lives, become familiar with issues, strive for social justice. So I do this, but I also help, provide Narcan. My family and I pass out coats during Christmas in the Tenderloin in San Francisco, right? I live a life that is affirming so that I can help other people do the same. We create an affirmative setting. This is something that's really important to me. So if I say Marsha P. Johnson, who knows who that is? Okay, so Marsha P., Sylvia Ray Rivera, all of these different people who contributed to Stonewall, who've contributed to Audre Lorde, LGBT history, all of those people are in my office. And it tells people, you're welcome here, I get you, don't worry. And so what we've done is we've kind of expanded that not just to my little office, but to our residential facilities. So this means that we post every policy that we have open for every client to see. We have a huge amount of stuff posted, maybe from here to here in the communal areas, so that they can see, in fact, you do have to sign a no hate speech policy. And what that also means is how affirming and empowering is it for the client to say, hey, I just heard XYZ word, I'm looking at the policy, how can we address this? So it really allows for that power and balance to kind of be checked and allow for the clients, A, to work as a group, and then B, empower themselves to say what they need to say, knowing that, safety is first. The last thing is that even with heterosexual or cisgender clients, we still talk about these issues. I had a client in group recently say, I don't trust women, I don't trust men, but I do trust the LGBT community because they're the only people who've kept me safe. And that's really amazing that this cisgender heterosexual man can identify that and then talk with the group about why he feels safer with those people. And for him, it's right, those people, but what that also means is that in the group, let's say there's some LGBT folks in the group, they then feel bonded to a man that they would have never felt bonded to before. The other thing too is it really challenges the binary, being as we do have a lot of trans-identified or non-binary folks who do come through our doors. It's really important that people be able to challenge in a safe way rather than challenge in an aggressive way. So here are some things that I think are important to read, as they're not from me who sits in a place of power, they're from the client. So we go through each day afraid that someone will hurt us because of who we are. Maybe let's close our eyes so I can just read it to you and we can just kind of sit with what it feels like. Okay. I believe my depression could have been far less severe if there were more resources available regarding gender dysphoria and treatment. I have used substances in the past to try to deaden the pain. Sometimes this bit has been a direct action after suffering as a gender minority and being treated as if I do not have value. So you can open your eyes. And I want to kind of ask the room, in this last one, when hearing that someone does not feel that they have value because of their gender identity, what does that bring up in us? And so if I know that it's kind of hard to sit in this space and it's uncomfortable to be uncomfortable, but I also think that it's really important. I am a woman of privilege. I appear white, I appear heterosexual, and I'm cisgendered. And so for me, it's really important that I'm not thinking about my experience as a client, but rather I'm thinking about the client's experience of themselves. And this is a great way to do that. Okay. So what does all of this mean for treatment? So a lot. It means that we need to be flexible and understanding. It means that we need to take a non-judgmental stance. So if a client comes to you and says, hey, I need XYZ modification, instead of us, fine, not that that necessarily happens, but instead of us being frustrated that they need something, approaching them and saying, absolutely, that's what I'm here for. Comprehensive treatment. So I am very fortunate that I'm a therapist who feels comfortable and is trained to provide all of these services, but it's also my job then in this place of power and privilege to make sure that everyone around me is trained so that we can truly provide comprehensive treatment. That means that we not only provide therapy, but we provide process groups, we provide acupuncture, we provide yoga and qigong, we provide somatic movement classes, we provide cranial sacral therapy. So we make sure, particularly for a community who Western medicine has said we cannot help you, that there are different services that feel like they are well-rounded, rather than someone stepping into just a medical office. We want them to step into a lot of different places that maybe feel more comfortable for them. We provide culturally humble and accurate care. So recently I had a discussion with someone letting them know that, cultural humility has been around now for maybe 8 or 9 years, and that's a shift away from cultural competency, right? So we want to make sure that we're coming from a place of humility rather than assuming because I've read an article on the Hmong people that I know what I'm talking about. I have no clue what I'm talking about, and I need to own that, right? I think that there's an importance of saying, I don't know, but I'm willing to learn, rather than I watched this one documentary, therefore I'm an expert. So we want to promote self-respect. And again, this goes back to if you post policies liberally and people can see what the policies are, they feel empowered with information to stand up and advocate for themselves. And for some people, it might be their first time advocating for their needs in an institution. We want to explore internalized homophobia and transphobia. So I have a reading list here for a lot of the particular white gay men that we see. We have them read The Velvet Rage, and it's really powerful for them. I don't know if people have heard of that, but it's a really important book about why gay men get to be so angry and why their life experience has set them up to feel anger and why it's okay to express, and let's move through it and work through it. We want to explore and promote safety and community. One of the examples I give is that, so we have a little communal area, and I was walking by and some people were saying, well, do you think this person has had the surgery or not, right? Which I saw your face, that's how I felt too. The face that I just saw was, right? So I walked up to the clients and I said, I think I might be hearing something that's a little bit inappropriate. I'm not going to be presumptive. Let me know what you were talking about. Total silence, right? So I went to them and I said, hey, I just want to let you know that we have this policy and that all 4 of you have signed it. Why don't you come into my office and we'll go over the policy together? And if it feels comfortable for you that you can stay here, great. If it feels to you necessary to talk about someone's body parts, then maybe we need to talk about why that feels necessary for you. We want to reduce barriers to treatment. So a beautiful thing that we have access to is insurance. We take insurance. We take Anthem. We take Kaiser. And now we're taking VA. So what that means is we have a really diverse mix of people. And what that also means is that we're going to get the farmer from Kansas, and we're also going to get the sex worker from the Tenderloin, right? And we have to make sure that they can work collaboratively and in a community and feel safe together. And if that doesn't happen or it can't happen, then I sit down, I have an open door policy, and I invite the clients in to talk about what's going on in the community. So lastly, we support collective decision making. So for example, a question that I get a lot, both in person and via email is, well, what's your policy? I'm going to use air quotes. What's your policy around housing trans people? There's no reason for this question to be asked, right? We're all people. And we don't house based on genitalia, right? We house based on gender identity and sexual orientation. And so for us, there is no policy. It's what do you feel comfortable with and how does your roommate feel comfortable? And we never ask a client to out themselves. So they sit down with me and maybe the clinical director and maybe another support staff, and we make a decision as a group so that the person doesn't feel A, that they have to out themselves, B, that they're in it alone, or C, that by just existing they are doing something wrong by rooming with someone else, right? We want to eliminate those barriers. Okay, so how can we provide more specialized care? Well, we can acknowledge exposure to microaggressions as significant trauma in treatment. As we're sitting here, I just kind of like to take the temperature of the room. How many people see microaggressions or microaggressive behavior or saw it previous to this presentation as significant trauma? Is this something that, okay, great. And is this something that you're talking about amongst yourselves and staff or with clients or both? Both? Okay. So I really believe that there's a lot of empowerment in giving people the language to talk about what's happening for themselves. And one of the things that I like to do is give language to the reality that this person has been told is not existing or is not happening. So if I say to someone, yeah, that sounds really, really painful that someone would constantly be clutching their purse. Or yeah, I bet it's really painful that You feel like you can't express your emotions because you're afraid you won't be safe. And then what we do is we lead into a conversation about microaggressive trauma. And it gives people language where they didn't have language before. For some people, I have to be really thoughtful about it, and maybe we don't lead into it yet if the safety and stabilization hasn't been established. But if they're a person who has high insight, maybe has one or two coping skills already, is able to de-escalate themselves on their own, then that's something I bring up and I give them language for it. So we train frontline staff on how to be culturally humble and how to create an affirming environment. So like I said, we have kitchen staff, we have maintenance staff. Every single person has been trained on how to address this. And what that also means is I have an open door policy. So if something comes up, if someone's having a hard time, or if someone maybe makes a mistake, they come to me, we talk it through, and then they go back to the client and they fix it. And there's a lot of people who have said to me, this is the only place that I feel safe, and I feel safe because everybody is willing to own up to what's happening. Nobody is telling me that my reality is wrong. So again, we adopt and we post non-discriminatory policies. It covers sexuality, gender identity, and expression. We have single occupancy bathrooms, and this was a big deal because we turned the bathrooms that have 2 or 3 stalls in them into single occupancy. So people can choose to close them if they want. People can choose to use the bathroom, together if they would like to. And for a lot of people, they've said it's really liberating. The other thing, I think that some programs get nervous that people will complain or feel unsafe. This has now been 2 years, and there hasn't been a single person who said, I don't trust this bathroom, or I don't like that there's multiple stalls in here and different genders and sexes can use the bathroom at the same time. There hasn't been a single complaint. And what this says to me is that I think that we have a lot of concern as providers about what might happen or how people might feel. And the thing is that if we don't provide the care, we don't know. And so for us, the single occupancy bathrooms felt like one of the biggest agenda items that we had to do the fastest. And we've only had people say that it makes them feel even safer. So providers are encouraged to talk to their patients about gender identity and sexual orientation. What I will say, though, is that we do not assume that gender identity or sexual orientation is the problem that brings them to treatment or to therapy. And I think that that's really important. Star, exclamation point, underline. Because if we assume, for example, that someone's identity or someone's homophobic family is the reason that they're drinking, we're already making assumptions. That's already a microaggression, right? So what I like to do, and what we've done at Bayside, is we changed all of our intake forms to reflect open spaces, to reflect that we don't need to check boxes, to reflect that we want to know what the person's authentic identity is. And what they can do is safely and in their own way, write down how they identify, give it to us, and then we can read it. And that kind of eliminates the pressure that the client might feel to openly identify themselves. And then there's going to be some clients who are really excited and want to tell us everything. I get those kinds. And lastly, we create and post nonviolent literature. So we are really big on the nonviolence issue. Most of the clients who come to us have very severe trauma. And so for example, we take a lot of clients who have traumatic brain injury. And for anybody who knows what that looks like, it's a little bit impulsive. Maybe they don't know how to have a quiet voice so much. And maybe they don't realize that they're being pushy or aggressive. Well, to someone on the outset who's had a really long history of trauma, that person looks like an abuser. And so we have to be really thoughtful about talking to that person about, hey, here's how your behavior is coming off. And then also talking to this person about, hey, without identifying what the other client is going through, here's ways that we can look at it, and that help make you feel safe. So community safety. We really, truly, this is of utmost importance. We ask clients not what is wrong with you, but what has happened to you. And I know that sometimes that sounds a little cheesy or canned, but I really think that it's profound. Because if we say, well, what's wrong with you? That's incredibly dismissive. It also inherently implies that there's a problem. Well, if someone's experienced trauma, of course maybe they're going to act out. Of course they're not going to believe that we can keep them safe or provide them accurate care, right? Rather than, oh, you have a father who is severely homophobic and kicked you out at 13. Of course you don't trust providers. Of course you're not going to trust that I can care for you or that I do care for you. We work as a group with open communication. What this looks like is that we're correcting each other constantly. So in a clinical training or in a group, if someone, for example, says she and the pronoun is they, we gently interrupt and say they, and then we move on. And it's happening like popcorn, right? And it's to the point where we don't even really notice it. And then new people or new staff come into the situation and they say, oh, what's wrong? Nothing's wrong. We're just correcting each other. And we'll have collaborative discussion. We help clients put their feelings into words rather than acting them out. This is a big one. So for example, the client who was really upset about the there she is or here she is, that client wanted to go to the staff member and really tell him off, right? Which makes sense. And we asked the client, what are ways that you can engage in your power that also respect you? Because if you're yelling and screaming and making a scene, after the fact, maybe you'll feel ashamed. Or after the fact, you'll feel like you have to overly apologize to the staff member. Well, what's a way that you could express what's going on for you and what your life experience is, right? What has happened to you that would cause this reaction. So they wrote it down. They said, look, nobody in my family respects my pronouns. I had to, disconnect any connection to all of my family. For me, when you did this, it felt like you were my dad. And that's something that I'm working on, and I'm deeply sorry about that. And I need you to be much more thoughtful about my pronouns. And it was fine, right? The other thing that this showed that client is that not every relationship has to either erupt or implode. So that because who I am, you don't have to either run away or I don't have to run away, that we can coexist and that there can be oopsies and that we can still move forward. And that every oopsies we have or every rupture we have that then comes back together only makes the relationship stronger. So if there's an issue within the community, we help clients think as a group. Again, we want to make sure that that client doesn't feel singled out as the problem. So for example, we had a client who I worked with, really lovely, who said, if I have boobs, I'm this person. If I'm not wearing boobs or makeup, I'm this person. And for me, it felt like, right on, you've made it very clear to me about who you are and about how you're showing up day to day. For me, it was very clear. For the clients, it was disorienting and I think a little bit scary, particularly because maybe they hadn't been around a person who shifted and was more fluid in that way. And so instead of me saying to this person, I need you to just pick one, or I need you to be more aware about how you show up in the community, we got together as a community and we talked about gender identity. And it was a really beautiful conversation. And it didn't have to be about this person. Instead, it was about how do we all identify. And then this person got to share, oh, by the way, I identify this way. So it was totally fine. And other clients ended up experiencing, wanting to put nail polish on, or maybe I want to wear glitter. It really opened up the conversation for people to get to identify however they want to in treatment. And it ended up being a really close community because of that. So we approach conflict resolution as a team. This is a big one. And we also create a learning and living environment. And part of that is going back to the cultural humility. We always want to be, educating ourselves. We always want to go to conferences, to read books. The therapists, we share books constantly. We give books out to the clients. We really want everybody to feel, whether it's staff, clinical, the drivers, whoever, that if you want education on something, it doesn't have to be shameful. It's not, oh, I don't know this. It's, I would like to be informed. And lastly, here are the definitions that tend to come up most for us. Ensure that by the sheer fact that all of you are in this room, I'm going to make an assumption that maybe you know these definitions. So the ones that I think are the most important. So preferred pronoun actually is now kind of debunked. People say that, my pronoun is not a preference, it's who I am. And so now what we say is, what pronoun do you use? We don't ask, what is your preferred pronoun? The they, them, their is very, very common, and it's the pronoun for non-binary folks that we see the most often. Gender identity is a person's internal sense of self and how they fit into the world. Sex is historically referred to your sex assigned at birth. And by the way, I used the phrase dead name. Do you people know what that means? Okay. So for the people who don't know what that means, a dead name is maybe the name that you were given at birth, but not the name that you go by. And so often we ask for both dead name and chosen name. And in all of our filing and all of our paperwork, we choose the chosen name. Sexual orientation is how someone's sexual attraction is experienced. But it's not directly related to gender identity, and this is something that's very important. Gender expression is the outward manner in which an individual expresses their gender. Being trans is a person who identifies their gender differently from the sex they were assigned at birth. Cisgender is a non-transgender person, a person who identifies with the sex they were assigned at birth. Gender non-conforming is a person whose gender identity differs from what they were assigned at birth, but is more complex in that it's fluid, multifaceted, and it's on a continuum. Again, that client that I mentioned who wore boobs one day and not the other day, that they identified as gender nonconforming. So trans-masculine and trans-feminine are terms used to describe gender nonconforming or binary people based on the directionality of their gender identity and how they show up. And lastly, drag, queen, and king. I really wanted to put this in there because I find that some clients think that because someone is transgender, they do drag. Two very different things. And I think we can kind of giggle in this room because we know that, but I think that it can be really important to remind people that someone's identity is not for performance, right? And delineate the difference between performance and costume, and how someone shows up in the world. Lastly, so I have a lot of recommended reading. And the reason that I include this as a slide that I actually talk about is because I think that there's particular books we can include in our practices or within the community that really tell people that we're safe. So if you see the ABCs of LGBT, it's a fabulous book for clinicians, families, and young people. It is both graphic and also provides definitions, so it's got great images. It really provides a good understanding of the definition of what you're looking at because it has really good illustrations. Full Spectrum, a new generation of writing about gay, lesbian, bisexual, trans, and questioning and other identities is fabulous. This book, The Fundamentals of LGBT Substance Use Disorders, is wonderful. If anybody finds that they have clients who work with or who have substance use issues, even if it's not necessarily that they qualify for a disorder, but that you find that they're using substances heavily to cope, this would be a great book. Also, Microaggressions and Traumatic Stress. It sounds dense, but it would be a really important and really good read and can be really transformative for how you think about your therapeutic practice. The Queerdiotic Table is great, and this is one that I have in my office more so as a coffee table book. And what I have is some clients who maybe feel uncomfortable or who feel nervous, they will flip through that book while they're talking to me. So it's a number of images, a number of different kind of moments in history, and it allows someone to look at something else and do something else while they're talking to me. The Stonewall Reader I'm reading right now. It's excellent, and it's a really good guide to LGBT history for the clinician. And The Velvet Rage. This is the book that I was referring to that I often have my gay cisgender clients read. And for a lot of people, it's overcoming the pain of growing up gay in the straight man's world, and it's a fabulous introduction to talking about microaggressive trauma or microaggressive discrimination. Also, Sister Outsider is great. Not only is it about the queer experience, but it's written by a woman of color, and those are really important books to read. And then the last one, Gender Outlaw by Kate Bornstein, is an excellent, excellent book. So I have a number of resources here. For the Bay Area, the top two are Bay Area, but the rest of them are national. And the Trans Lifeline and the Trevor Project, the GLAAD and the Human Rights Campaign are all ones that you can call, and they will be really available for resources. They're also great places if you have clients who maybe don't have a community hub or don't have a place to go. Maybe they don't know how to meet other queer people. These are great places to do that. So I wanted to open it up for questions for 15 minutes. I know I'm 2 minutes ahead of time, but did anybody have questions? Whether even if it's a case question or how do I do this in practice, how do I do this at my organization? Yeah.
Okay, so on a pronoun question.
Mm-hmm.
So I've been in a lot of meetings lately where people start off meetings by saying, here's my PGP, right? That's been happening a lot in the past few years.
Yeah.
A colleague of mine, a former colleague, wrote an article saying she used to do that, stopped doing that in classroom settings because people would just break down crying. That they would feel, well, what do you mean? Why are you asking me? You can't tell. It's not obvious. Meaning I'm not passing. Can that be very upsetting?
Yeah.
Or I don't know. And now I'm being asked to tell you.
Yeah.
So I'm wondering if, and I was just thinking as you were saying this, is that maybe actually a microaggression as well? Is it possible that? So just wondering your thoughts about opening spaces, asking people to discuss.
Yeah.
What's that been like for your clients?
So I want to preface that by saying that I think presuming that someone feels safe or stable in an environment is a really big assumption. Mm-hmm. And if we start classes, therapy groups, whatever, a conversation with our pronouns, we are assuming that that person feels safe enough to tell us theirs, right? And so I understand kind of this wave of moving toward wanting to be able to be open. And I agree with you that it could potentially be very fearful, concerning, scary. It could also make it so that that person never comes back to that therapy group again, right? So I think that this is a tough one. It's kind of a both and it depends. I have to tell you my email signatures, the way that I show up in the world is I say my pronoun, but I never assume that someone else needs to or that they will. And I also like to be thoughtful that if I'm in a position of power as Dr. so-and-so, I'm not going to assume that there's safety in a room for someone to tell me how they identify upon first meeting me. So does that kind of answer your question? I don't know that it's a microaggression. Would I say that it challenges community safety? Yes. And would I also say that it's presumptive? Totally. Yeah. Thank you for that question. It's very interesting. Yeah.
Could you just go back to the resources?
Oh, totally.
Get a picture.
Yeah. Okay. Okay. Yeah.
How do you talk about sort of the concept of microaggressions and trauma to your clients? And I guess specifically, I'm wondering, do you ever experience any pushback from clients who feel like they don't want to take on the stigma of a traumatized identity on top of having to deal with some stuff?
Yeah. So that's why I prefaced this with kind of a big but and a big and, which is that I come from, so previously I was working in an emergency department responding to rapes on call in an ER. So my trauma response and my trauma experience is that I never assume that someone feels safe. And so the big thing is that if I have a client, for example, who is severely traumatized and isn't able to use the coping skills such as grounding, deep breathing, mindfulness, just the ability to kind of bring themselves down or bring their central nervous system down, I'm not going to have that conversation yet. And so I try to really track how the client is doing, what coping skills they already have, if they're able to even guided do some coping skills before I'll have that conversation. And I also definitely experience people saying, don't label me as traumatized, right? Which I never do. However, that doesn't mean that their experience isn't real and their experience is that I'm labeling them as traumatized. So I try to be really thoughtful about that. So it's a yes and conversation, which is that I try to be preemptive about really tracking how the client's doing before we get into that conversation. The opposite is also true, that maybe you find clients who do the verbal dump on you. I don't know if you have clients who do that, but I have some clients who come in are very pressured, want to tell me all of their trauma right away. And actually, I don't let them do that. So my rule is let's talk about trauma, not in details, but as if it's the headline of a newspaper. So instead of getting into the nitty gritty, bumping up your central nervous system, getting rid of your coping skills and becoming flooded, let's talk about what the one sentence of your trauma might be, and then slowly get into the details so that you can slowly learn coping skills, and then we'll have that conversation. Does that answer your question?
It does, yeah.
Okay. Yeah. Any other questions? Yeah, oh, yeah, we'll go here and here.
This might be another and but kind of
I feel like they
question,
kind of all are, but.
I'm not even sure how I want to word this, but it sounds like a big premise of your guys' center is like, of course, creating safety.
Yeah.
Want it to be a safe space. I'm glad you brought up that you guys try to explore and work with people who are having internalized homophobia. But I've worked with some clients who have very severe
Yeah.
internalized homophobia. It can be very negative, probably have some hate-oriented speech about the community, about themselves.
Yeah.
So I'm curious, have you had, and if you have, how you navigate those spaces within the group therapy context? Because here you are trying to create a safe space, and here's someone who's having internalized homophobia or transphobia
Yeah.
and being maybe using words that are very oppressive or microaggressions towards people in their group.
Yeah, I really appreciate that question. So one of the things that I think I also stress in talking about this is that the reason that someone maybe shows up as internally homophobic or transphobic is because society, their family, their medical institution has kind of contributed to it, right? And so I frame it as outside of them. So I'm a narrative therapist. And so what I do is I talk about the narrative that's contributed to why they might feel this way. And by locating it externally, then they don't have to take on the shame and the guilt and the hurt and the anger. They get to say, oh, I have adopted this way of thinking or feeling, which means I can also choose to let it go. Does that mean that it's a really long process? Yes. So that's maybe where the and comes in. However, I firmly believe that if we are in therapy and we're not looking at sociopolitical factors, socioeconomic status, family dynamic, religion, gender roles and norms that they know, then we're not looking at the whole picture. So that being said, if we remove those things from the client and say, make up a name, what does Jay want? And just ask them, let go of any expectations, let go of who you think I need you to be, who would you like to be and what's coming up for you. Often clients will start crying, but then once they, breathe a little bit, they'll say, Jay needs love, or Jay needs family, or whatever it is, and then I work with that. I agree with you though that there's going to be anger, there's going to be intensity, and this is all again about sitting in discomfort. So I had a client who came out to me. I was the only provider that he had decided he could come out to, and we sat together for 25 minutes in silence because now I was holding his secret and now he didn't trust me. So it shifted, but that's okay. It shifted the dynamic, which was necessary, and he needed someone to know. But then I was the person holding it, and he felt like he couldn't talk to me. So there's always going to be these relational shifts that come up. But fundamentally, if we locate these things outside of the client, I think it makes it a little bit easier for them to deal with. Did that answer your question? Okay. And then
I'm curious about just the process of becoming more affirming in terms of your center, and how you dealt with any sort of overt or subtle resistance from staff that may have come.
that's a great question. So I want to be thoughtful in that I don't want to speak for people. Thank you. That I, don't know fully or personally. But what I think it was is a little bit of pushback around discomfort of being uncomfortable. That, well, I don't need to know this because I don't want to mess it up. Oh, which is almost the opposite of what we would think, right? Like, let's get educated so we don't mess it up. I think there was kind of a denial and for some very few people, on the whole, it was very accepting. Most people were really excited about it. And then maybe we had one or two people who said either, I don't think people are going to get it, or I don't get it, therefore I don't want to learn it. And those people slowly came around because they realized that it was a really important service, and that, again, LGBT affirming services don't change anything. We should be doing all of this stuff for everybody all the time. And when we framed it like that, I think people were able to digest it a little bit more. Yeah.
Good
question about how you handle situations where you're sort of thinking, like in my situation, people are coming to me for hormones, and I'm gonna write for the hormones. And part of that assessment of if they're ready for it, involves asking a lot of questions that can feel probing. And the same for my mental health colleagues who are providing letters for surgery. And how do you kind of walk the line of making someone comfortable asking what you need to ask without being completely intrusive and off-putting?
So I'm radically transparent. Emphasis on the radical.
Yeah.
So the exact same way that I'm talking to all of you is the exact same way that I talk to my clients, that I talk to my dog, that I talk to my mom. And by doing that and naming like, hey, I'm in a position where there is a power imbalance and I understand that that's there, and please know that I put myself in this position so that I could help. I am not here to keep you out, I am here to bring you in. And also naming, like, these are conversations that we're going to have so that I can help you. They're going to be uncomfortable and I want you to guide them. So I always tell my clients that I am not, coming from my reality, I'm stepping into theirs, and that they are the master of their own reality. And so I need them to come to me in order for me to help them. And when I do that and I let the client know that they're in the position of power and they get to tell me what they need to tell me so I can help them, it shifts the dynamic a little bit. And there's also going to be clients who feel uncomfortable, right? And you can name that and you can say, I really hope that we can work on you feeling more comfortable, or I really hope that if at some point you do feel very uncomfortable, you can tell me. And I find that when I am radically transparent and tell people that I'm going to approach it that way, the walls kind of drop down. But again, I agree with you. It's really difficult. I went to school so that I could help people and help my community. Both of my godparents are trans, right? So these are people who are really close to me, and I'm a queer identified person. So sometimes if the client really can't get there, I'll say, hey, I'm safe, I'm a member of the community, and then I leave it at that. And if you're not a member of the community, you can say, it's really important to me that you get the care you need, but I can't give you that care unless I have a particular amount of information. So being really blunt about it sometimes can be really helpful. It takes the gatekeepery dynamic away a little bit.
I have a kind of a clinical question.
Sure.
It's a little bit complicated, so okay, you can't answer it. So I have a client who referred to that book, The Velvet
Rage.
And just completely identified with that. He's in his mid-20s.
Yeah.
And has had clearly a tremendous amount of traumatic microaggressions and discrimination throughout his life. So he's been in treatment with me for about 5 years, and he's never had a relationship, and is very uninterested and scared to engage in the LGBT community at all. And so that question about internalized homophobia sort of triggered my feeling of what do you do? Like he's stuck. I'm sort of at a loss. So I just had a question about what is your approach in terms of getting connected in the community? Yeah. How would you bridge that? Do you have any brilliant ideas?
Maybe not brilliant, but I have ideas. And I'm going to first be annoying by answering your question with a question, which I hate. But have you ever named hey, I feel really stuck? Are you feeling stuck?
Yeah.
Okay, and then what happens?
He feels stuck too.
Okay.
And he's able to say that he is just extremely risk averse and terrified. He's really traumatized by taking risk in all kinds. It's not just in this part of his life, but in every part of his life, feeling terrified. So it feels like a global issue.
Yeah.
But the risk taking, he's very risk averse.
Okay. Are there any places in his life where he experiences connection?
Yeah.
Where are those?
Like with his friend group. It's a straight friend group, but he.
Okay.
Yeah.
I'd be curious about what in fact does he feel connected to, and if he feels connected to straight men, then that's fine.
Yeah.
And I would also reflect to him that he probably feels connected to them because they don't reflect who he is, and that feels safer for him. And that being in a community is looking at his own reflection, and that might be really difficult. And when he looks at his reflection, what does he see? And if you ask him, when you look at your reflection, what do you see? It illuminates those things that maybe he wouldn't authentically come up with on his own. You know what I mean? I think that sometimes there's some prompting that's needed and we have to get creative about the prompting. I have a little picture of a wardrobe that has a mirror in it. And I ask people two things. I ask them the global question, which is, what would your life look like if it were perfect? What's your utopic world look like? And I ask people, what do you see when you look at yourself in the mirror? And then I ask them to draw it in there. And then based on that, those are the goals. Those become the goals. So if someone says, well, I just see something I really hate, then let's talk about the hate and let's work on that and let's figure out where that hate's coming from. Maybe someone says, I see someone who's amazing and attractive and bodacious and all of these things, and maybe they're only reflecting two things about image. I see that you're only reflecting things about your image. I'm curious about other parts of you. So using those kinds of things in order to get curious, because I think what can happen when we feel stuck is two things. One, we get frustrated and kind of shut down with the client, and we join them in that space of hunkering down like a rock. And the other thing is that if we aren't infusing newness into the practice for the 5 years, which I'm sure you are, because even having him read the book is huge. I think that we have to get really creative at some point and do things that almost make us feel uncomfortable in order to shake things up. So the mirror one, I think, can be really, really helpful.
And you said that was like asking about it's a utopic world, and then what do they see in.
Yeah, and then if whatever comes up in what they see in the reflection, asking about that. And then I ask about the experience of doing the exercises. So what was it like for you? Was it uncomfortable? Did it feel easy? Did you do it 5 minutes before you came to session, right? Like,
Even experimenting more kind of. Okay.
Yeah. The other thing, the last thing I would say is I get curious around coping skills for this person. If he's drinking a lot, if he smokes weed, if he is a person who is relationship adverse, that therefore he's constantly isolated. I'd be curious about those things. And in that, I would urge the client to move toward opposite action. So whatever he finds himself wanting to do, ask him to do the opposite and see what the outcome is.
Thank you.
Did that answer your question?
Yeah, thank you.
Given that the LGBT communities can oftentimes be segregated, and
Sure.
certainly not immune from racism, systemic racism.
Yeah.
How does your center address that particular issue, particularly for queer people of color who may feel safer opening up to someone who's a better identity match for them?
Then I urge for them to say that. Instead of sticking them, well, they're not stuck with me, but having them see me and having them feel uncomfortable, I ask them what therapist would they like to see, and if we don't have an exact match, then we talk about the frustration of not having an exact match. We talk about the fact that it feels to them maybe microaggressive, that they can't find the care that they need. We talk about stigma around not being able to have providers that reflect their experience. Like I said, I approach all of this with real intense transparency, and so we have really direct conversations about it. And then what we also, Then what we also do is we make sure that we're referring to places that meet their needs, and we start those referral conversations the week they get to treatment. So even if the person's entire treatment is struggling with a relationship with an Indigenous queer cis woman, then we talk about that. We talk about how we can work through relationships. We talk about relationship dynamics, and we also refer them to someone who's going to meet their needs. But again, I will not have a good answer for that, because I think that until we have a gateway to clinicians who represent everyone, there will always be a need that's unmet. And then I think you're going to be the
I
last
just wanted
person.
to add to that from my personal experience in that being the queer, biracial male therapist, right? So initially I thought that was the thing by practicing and being that base. Great, right? But for some clients, that internalized homophobia actually projects on me.
Yes.
And they can't have me as a therapist.
Yes.
And that was a very difficult thing in my own practice to realize. Because I was like, where's this coming from? I'm like, I thought, oh, this is gonna be a great relationship, and no, it's the alternative. So sometimes that will prevent
Yes.
moving forward for them as well.
Yeah, I'm an open queer counselor, and there have been times when I've referred a queer student of color for an identity match purpose, only to have them come back to me because they really felt more of a connection with me.
Can I ask
I
a
think more the
question?
exception than the rule.
Yeah, are you referring clients out for an identity match because they've asked for it?
Because it's come up in discussion. Not necessarily because they've asked for it.
So that's the thing that I would be thoughtful and cautious about, is that for a lot of people, I mean, we're queer community members, so I can't speak for anybody, but I can speak in my experience that the idea that because we talked about it means that I need to refer out may actually make the client feel that I don't want them, or that I don't feel that I don't want to work with them. None of that can be true, but the experience of being referred and then having to come back can be kind of a shameful experience. So I don't refer out for an identity match unless specifically and very overtly asked for. And these are all really transparent conversations that we have with the client. But in my 2 years at Bayside, that hasn't happened. Are we at time's up? Almost. Okay, is there one more question? No. I think we might be. We have 1 minute. If anybody has a 1 minute question, great. If not, that's okay. I will be available for questions, and my information is here. And Mila's information is here as well. We really mean it. We've met people at this conference and we say, come take a tour, come spend a day with us, come have lunch up at our facility. I take time out of my week every single week to meet new providers and have them come visit us. So please do that. If you want a card, I have them, and so does Mila. It was really, really lovely to present for you all, and I really appreciate how active all of you were in this discussion.
Thank you.